Hello and welcome to Grand Rounds. I'm Andrew Wright, Assistant Professor of Surgery at the University of Washington Medical Center. And today we're going to be talking about treatment of obesity with surgery. So we've been performing weight loss surgery at the UW Medical Center since 1978. We were really pioneers in this area and have taught most of the folks in the region that are now performing this type of operation. Our team is really a multidisciplinary team, and it's important to know that surgery for obesity is a team sport. It's not just the surgeon. It's the nurses, the dietitians, the social workers to help maximize the odds of success. There are 4 of us at the UW Medical Center that perform this operation. There's Dr. Dellinger, Dr. Flum, Dr. Kandawal, and myself. We all perform gastric bypass, and Dr. Kandawal and myself also perform laparoscopic adjustable gastric banding. We are ranked highly by U.S. News and World Report, but more important than that to me is the fact that we're ranked at the highest level, Level 1A, as a bariatric surgical center by the American College of Surgeons. And what that means is that an outside auditing body comes in and actually reviews our program and makes sure that we have all of the processes and all the people in place, again, to try to maximize the odds of success. Also, equally important to me is the fact that we're a magnet hospital for nursing. And that, I think, really speaks to the fact that this is a team approach. Surgeons, nurses, all of our whole team working together for you. Well, we all know that obesity has major impacts on health. It's estimated that there are 300,000 lives lost every year in this country due to complications of obesity. The big 3, diabetes, high blood pressure, and cancer, major health issues that impact your quality and length of life. But also it decreases your quality of life, the ability to pick up your grandkids, to go to work, and to perform at a high level. It impacts every component of your life, from your health to your family to your work. There are a whole raft of problems associated with obesity: heart disease, lung disease, diabetes, cholesterol. You can see the list, it goes on and on. But to me, again, that impaired quality of life, the effect that it has on how happy you are and how able you are to be with your family and to live a quality life, that's really why I'm in this area of bariatric surgery. Well, although I'm a surgeon, I am the first to admit that surgery is not for everybody. And the important thing to know is that you can lose weight through dieting and exercise alone. And if you can, then you don't need surgery. Unfortunately, most of the studies in the area of weight loss without surgery show that weight loss is pretty modest, somewhere between 5 and 10% of your total weight. And most of that weight comes back on within a year or 2. And we all know that phenomenon of losing weight through dieting, but then putting all that weight back on and then gaining even more weight afterwards. That being said, even modest weight loss can be very good for you. If you lose even 7% of your weight, your risk of diabetes goes down by 50%. So it's not to say that surgery is for everyone. So if that's the case, who is surgery for, and what do we look for in a patient that might benefit from bariatric surgery? Well, first of all, not every weight is the same. We don't expect a 5'2" person to weigh the same amount as a 6'2" person. So we combine height and weight in something we call the body mass index. And there's a calculator available online. You can go and look up your own body mass index. But just as an example, if you're 5'1" and you're 250 pounds, your body mass index is 48. Now we consider anything over a body mass index of 30 to be obese, and everything over 35 to be morbidly obese. So who qualifies for surgery? Well, every insurance plan is different, and you have to check with your own insurance plan to see what their rules are. Now, we tend to follow what are the NIH, or National Institute of Health, consensus criteria. So if your body mass index is over 40, or if it's over 35 and you have a weight-related health problem, like diabetes or sleep apnea, then that tends to qualify you, at least in my eyes, for bariatric surgery. It is important that you're not smoking, because smoking increases the risk of surgery, and that you don't have an active drug or alcohol abuse problem. Well, what operations do we offer? Really, there are 2, the adjustable gastric band and the Roux-en-Y gastric bypass. And I'm going to talk about each of those in turn. So the gastric bypass is the older of the 2 operations. It's been around for about 20 years now. And in the gastric bypass, the first thing we do is make a small pouch, about the size of an egg, and that's made at the top of the stomach. So we divide this pouch from the rest of the stomach. Now, by making that small pouch about the size of an egg, it restricts the amount of food that you eat. You only eat a small amount of food, then you feel full and can stop eating. Now, of course, we need some way for food to get out of that pouch. So we take a piece of the small intestine and we bring it up to the pouch and connect it. By doing so, we're bypassing the stomach and the first part of the small intestine. Now, that causes weight loss for a couple of reasons. The first, and probably the most important, is that small pouch restricts the amount of food that you eat. It only takes a small amount of food to fill up that pouch so you feel full and can stop eating. It also slightly changes the way we absorb our food because that food is going straight into the small intestine instead of going through the rest of the stomach and the duodenum. It also encourages healthy eating. One of the side effects of the bypass is if you eat fatty foods or foods that are unhealthy, it tends to give you what we call dumping syndrome, bloating, diarrhea, gassiness. Now, that may sound like a negative, but from my perspective, that's actually a positive because it teaches you pretty quickly what foods to avoid and what foods are good and healthy for you. Also, very interestingly, this operation changes the hormones that are involved in appetite and in blood sugar and insulin. And it does that because a lot of those hormones are made by the first part of the small intestine and the pancreas, that very same part of the intestine that's bypassed as a result of this operation. Now, what can you expect after a bypass? Well, almost everybody loses a very significant amount of weight. It is not, however, very easily reversible. Once it's done, the operation's done. So what are our goals? Well, the goal is about 1/3 of your pre-surgery weight. So if you weigh 300 pounds, our goal would be about 100 pounds of weight loss. Now, most people will lose a lot of weight. Not everybody hits their goal, and a lot of that depends on diet and exercise. The folks who tend not to do as well or who regain weight are folks who make poor food choices, who are eating fatty foods or sugary foods, who graze or binge eat throughout the day, or who don't exercise. Now, that weight loss is fairly rapid. If you start up here, most people lose the weight in the first 6 to 9 months. People tend to gain a little bit of weight after that over the next year or so, and then that weight stays pretty steady out even as far as 14 or 15 years. Well, what are the benefits besides weight loss? Because to be honest, the absolute amount of pounds that you lose isn't that important. What's important is the impact on your health and your quality of life. Well, diabetes gets better in most people, and in fact, it resolves completely, in other words, off all medications, in 70 to 100% of people after a bypass. High blood pressure tends to get better, sleep apnea tends to get better, acid reflux, and most importantly, again, quality of life improves after the bariatric surgery. Of course, there are always risks to go with any reward, and surgery certainly has its own risks. So what are the risks after a gastric bypass? Well, first of all, you can have death or a major complication. And the risk of death after this operation is somewhere between 1/2 and 1%. In other words, 1 in 100. And that can be from a leak from the intestine, from bleeding or blood clots, heart attack, stroke, etc. There are also some late complications. In other words, not things that happen in the hospital, but that may happen years down the road. The most common of these is a bowel obstruction, where the bowel actually twists and gets kinked off, and that keeps food from going through the system. And that can happen in as many as 1 in 20 people. You can also have nutritional deficiencies, problems with vitamin B12 or getting enough protein. And again, that can happen in 5 or 10% of people. Wound infection used to be very common when we did these operations through the old-fashioned open incision, through a big upper incision in your belly. Now we do most of these operations laparoscopically with teeny little incisions, teeny instruments, and a camera. And that's reduced our rate of infection and hernia. All told, about 1 to 5%, or about 1 in 20 people, will need another operation in their lifetime for some problem or complication related to their surgery. Well, what to expect? If you have the surgery, it usually takes us about 3 hours to do. You stay in the hospital for 2 nights. And if you have sleep apnea or a lot of health issues, you may need to stay in the intensive care unit that first night after surgery. We do want you to stick around close for about a week after surgery. If you live over across the mountains in eastern Washington, we don't want to have you back home 2 or 3 hours away from the University of Washington Medical Center and need to get a hold of us. So we do ask that you stick in town for a week. You are on a liquid diet for 2 weeks after surgery. We do want you up and moving even the day of surgery, and we certainly want to encourage an exercise program once you go home. We have you come back at 2 weeks after surgery and again after 6 weeks, and then every 3 months for the first year and every year after that. And those checks are to make sure that you're eating the right foods, that you're on track with your weight loss, and that you're not having any problems. Well, what about the laparoscopic adjustable gastric band? The band is really a tool to manage your appetite. Just like with the bypass, we make a little pouch at the top of your stomach about the size of an egg. Here, however, we make that pouch not by dividing the stomach, but by wrapping a band around the top of the stomach. So in this model of the stomach, you can see food comes in through the esophagus, fills up this pouch, and then here's the band, so it restricts the amount of food that you eat. Now this band is adjustable. It's attached by some tubing. And you can see here that the band actually has a balloon. That balloon can be inflated or deflated depending on your weight loss and your appetite. So it's attached by this tubing to a little port that sits underneath your skin. And this port has a little membrane. We can stick a little needle in here and inject some saline, or we can take some out and thereby tighten or loosen the balloon. So we can make the band tighter or looser depending on how you're doing. Now, all the band does is it makes it easier to feel full with eating a smaller amount. So it controls your hunger and reduces the amount of food that you eat. Unlike the bypass, it doesn't do anything to change the way food is absorbed, and it doesn't do anything to change the hormones that are involved in eating. So it's really just a tool. Now, just like any tool, if you use it the right way, you can have great results. But if you don't use the tool in the right fashion, you don't get the results you want. So the tool, the band, really requires a commitment to lifestyle changes. And that means healthy eating and exercise. The other thing that it requires is a commitment to coming back for the adjustments. Now, we know that a band might be too loose or too tight based on how you're feeling. So signs that it might be too loose is if you're hungry between meals, if you need more food to feel full, or if your weight loss has slowed down. And signs it might be too tight is if the food sticks as it goes down, or you have a lot of regurgitation, food coming back up after you eat. What we want is the band to be not too tight and not too loose. Just like Goldilocks, it needs to be just right. We call that the green zone. And in the green zone, you feel full after a very small meal, and you stay full between meals, and that you have a steady 1 to 2 pounds of weight loss per week. So our goals with the band are a little bit more modest than after the bypass, about 1/4 of your weight. So if you weigh about 300 pounds, our goal would be to lose about 60 to 70 pounds. Now, a lot of folks reach their goals, but some don't. And the folks that don't reach their goals are those who don't come back for an adjustment. If you don't come back for 6 months or a year, you're not going to lose the weight. If you don't eat the right foods, if you cheat by eating fatty or sugary foods, you're not going to lose the weight. And if you don't exercise, you're probably not going to lose the weight either. The weight loss is much more gradual than after the bypass. Again, our goal is 1 to 2 pounds a week, and it may take 2 or 3 years to reach your final goals. Now, just like the bypass, the band has a lot of positive impacts on your health. Diabetes gets better in about 2/3 of patients, high blood pressure, sleep apnea, heartburn. The other big advantage of the band is that it is adjustable, and we can tailor the band to you and your own particular needs. Nothing is without complications. Early complications after the band are less than after the bypass. So the risk of death or a major problem is about 1 in 1,000 instead of 1 in 100. You can have bleeding or infection, blood clots, all the usual things that you can see after a major operation. There are some particular complications to the band that can happen late, months to years after the band goes in. The band can wear a hole in the stomach. That's pretty rare, less than 1%. The most common thing that can happen is the band can slip out of position. So if we sew that band into the right spot around the stomach, if you eat too much, if you vomit, if you have trouble, that band can slip out of position. And if that happens, it needs another operation to move the band back to where it's supposed to be. And that can happen in 1 in 20 people. You can have swallowing problems if you don't ever get used to the tightness or the restriction of the band and feel like food is getting stuck all the time. And we've had to remove a few bands for that reason. That port that sits underneath your skin, that can flip or get out of position and again can need to be readjusted. All told, those complications, although they're real, are fairly easy to take care of. I think a bigger issue with the band is the fact that you can not lose weight. And in about 10 or 15% of people, they have problems reaching their goals losing weight with the band. And typically, again, that's because they either don't get adjusted or they're choosing the wrong foods. Well, what to expect with surgery? Surgery is a little bit faster than the bypass. Usually takes us about an hour to an hour and a half. Stay in the hospital for one night. We do keep you on a liquid diet for 2 weeks, and then we put you on a soft diet for another 2 weeks after that. And that's just to make sure that no chunky food goes down and gets stuck while the stitches are healing. We do want you up and moving right after surgery, and we do need for you to be on a long-term exercise plan, and that really helps accelerate the weight loss. We see you at 2 weeks. At 6 weeks, we see you again, and really that's the first time when we would consider doing an adjustment. And then we see you about once a month for 6 months, about once every other month for 6 months, and then we see you as needed, depending on your weight loss. So who's going to be successful with a band? Well, the most successful patients are folks who've been able to lose weight in the past. You've proven that you can lose weight through dieting. You just need help sticking with that diet in the long term. Folks who can exercise daily, who can stick to an exercise plan, do much, much better after the band. Folks who can follow the diet. And people who can come back for those adjustments. We do know that patients that come back to our support groups lose more weight and do better. I mentioned earlier about laparoscopic surgery. We used to do most of our operations through big incisions. Nowadays, we do most of our operations through little teeny incisions, usually 4 or 5 teeny little incisions using a camera. That's called laparoscopic surgery. And we can do laparoscopic surgery in about 90% of patients. The advantages of laparoscopy are that the recovery is faster and the pain's less. Every once in a while, we can't do it laparoscopically, and we still have to go back and do the old-fashioned open operation. So what operation is right for you? Well, a bypass has faster weight loss. Almost everybody loses the weight they want to lose, and it may have more of an impact on diabetes, and that's because of those hormonal changes that you see after a bypass. Now, we don't know that for sure yet, and we're still doing research at the University of Washington Medical Center to help clarify that question. It is a higher risk, more complicated operation, longer recovery. And then the dumping issue or the feedback issue is both a positive and a negative. If you eat the wrong foods, it makes you feel sick to your stomach. Now, that's a good thing because it teaches you to eat the right foods, but it's a bad thing if you constantly are feeling nauseated. The band is certainly a lower risk operation. The weight loss can be about the same, but a lot of patients don't lose the weight they want. Now, folks that we consider to be at risk for not losing much weight, folks who have a very high body mass index, over 55, people who are inactive and can't comply with exercise, people who have never lost much weight in the past with dieting, and folks who can't come back for their appointments, or who graze or binge eat. Now, one other note, there's a newer operation called the sleeve gastrectomy. In the sleeve, what we do is remove about 90% of the stomach. When you do that, it turns the stomach essentially into one tube that goes straight from the esophagus down to the small intestine. Now, the problem with this being a newer operation is that we don't know the long-term results of the sleeve. The early results, 3 or 4 years out, are very promising, but we don't know what happens in 10 or 15 years. Because of that, a lot of insurance companies don't cover the sleeve yet, but I think we're going to be hearing more and more about the sleeve over the next few years. The sleeve works by controlling hunger. Again, by making the stomach smaller, you don't have to eat as much to feel full. So it reduces the portion size, and it may affect the hormones that involve appetite. Again, the early weight loss is probably similar to the bypass, but we don't know much about the long term. So what you need to know, any of these operations, the operations themselves are a tool. They don't cause the weight loss. They're a tool to help you lose weight. They work better if you come back to see us and follow up, and they work better if you exercise. Now, everyone's insurance plan is different, and the insurance can be challenging, and we'll work with you to work with your insurance company. You have to get your records from your primary care doc, from your specialist, and it helps if you have documentation of your weight and documentation of attempts at losing weight. Sometimes those are needed to convince the insurance company to cover this operation. So the road to success starts with the evaluation, the nutritional evaluation, the social support, and the care after discharge. I'll talk about each of those in turn. So the goal of the evaluation, you come in for your first visit with the surgeon. So the goals of that appointment, is weight loss surgery right for you? And if it is right for you, which operation is the best for you? And are there any risk factors or medical issues that you have that we need to address before surgery to try to make surgery as low risk as possible? So you see the surgery staff at least twice. If you need it, we may have special tests or consultations with experts in different areas. All, again, trying to make sure that you're as healthy as possible going into surgery. At that first appointment, you need to bring in your weight loss history, history of your diets, your notes from your primary care doc, any notes from prior operations you might have had. And then any tests that might be relevant, heart tests or lung tests that might help us in deciding what is needed for you. Everyone sees our social worker. That's not meant to be a barrier to surgery. That's meant to identify the things that can help you succeed. So we'll talk about the impact of surgery on your life and on those around you. We'll talk about the care plan for after surgery and try to identify any issues that need to be addressed before you go to the operating room. If you are seeing a therapist, our social worker will want to talk to your therapist to try to identify any issues that need to be addressed. And if you need to find a therapist, we can help you with that. Our social worker also runs our bariatric support group. And again, patients that go to our support group tend to lose more weight and do better than those that don't. I mentioned before, no smoking. Smoking dramatically increases the risk of surgery. So our rule is no smoking in the 3 months before your surgery. And in fact, we'll often check a urine test to make sure that you haven't been cheating on the side. If you're having trouble quitting smoking, we can help, or your primary care doctor can help. There are a lot of great new medical therapies that help you quit cigarettes. Everyone who comes in also sees one of our nutritionists, and the goal of that visit is to identify your current eating patterns, to figure out what triggers you might have for eating and what patterns like binging or grazing might impact your weight loss, and to start trying to make changes before surgery that can help maximize your chance of success. For example, eating and drinking more slowly, or cutting out sugary carbonated beverages. Now, 3 weeks before your operation, we put you on a very low-calorie diet. And the reason we do that is not just to torture you, but it's actually to help make surgery safer. The first part of your body to lose weight is your liver. If we put you on a very low-calorie diet for even a few weeks before surgery, and your liver shrinks by just a small amount, that actually makes surgery safer because the liver sits right on top of the stomach, right where we need to be working. And so, again, we're doing that for a very specific medical reason. After your surgery, again, you meet with our nutritionist. Early in the period after surgery, with both the bypass and the band, you'll be on a liquid diet. And we count as a liquid diet anything that can fit through a straw. Once you start adding foods to your diet, start with soft foods, oatmeals, mashed potatoes, and then add food over time as they tolerate them. It's important to make sure you get enough protein, especially because you're eating less, you have to eat more healthy. Our nutritionist will also work with you to make sure that you maintain your weight loss in the long term. So that means lifelong healthy eating and portion control, and an exercise plan. It's also important to make sure you get enough liquids. Now, everyone will need to be on a multivitamin for the rest of your life, again, because it's hard to eat enough healthy foods. Folks after a bypass will also need vitamin B12. You'll also meet with our nurses, and our nurses will talk to you a lot about success after surgery. So things like how to avoid medical problems, or what to do if you have questions, preventing blood clots, when to call the doctor, when to resume driving, basically when you're off narcotics, contraception needs. And that is actually important because fertility goes up after bariatric surgery. With weight loss, so fertility improves. So we want to make sure, although it's safe to get pregnant after surgery, we want to make sure that that's done a year or so down the road, once you've lost the weight and gotten into a healthier state of being. It is important to make sure you come back to those follow-up visits. So we check your weight, we check your nutritional status, do lab tests to make sure that you're really on track. We get a lot of questions about medications. And the first thing to know is that depending on your particular health issues and your particular medications, that answer may vary. So one of the things that we do is have our pharmacists work with you to make sure that your medications are really in the right place where they're supposed to be after surgery. In general, you're going to want to avoid anti-inflammatories like Advil because they tend to cause bleeding issues. And some other medications have issues like blood thinners, for example. So again, our pharmacist and your primary care physician will have to work to make sure that your medication regimen is perfect for you. Now, for all of our bypass patients, because of the risk of blood clots after surgery, we put you on a blood thinner called enoxaparin. And that blood thinner is given once a day or twice a day for the whole month after surgery. And we'll teach you to give that injection to yourself. As I mentioned, pregnancy is very possible after surgery. Pregnancy is safer, though, if you can wait till after the weight loss. So we do ask that you wait for a year or two if you're trying to become pregnant. And of course, if you do become pregnant, you need to work with us and your nutritionist to really make sure that your child is getting the proper nutrition. Now, drugs and alcohol have some issues. A lot of folks with food issues also have alcohol or drug issues. And we need to make sure that those are really in treatment or taken care of before surgery. Also, alcohol in particular after surgery causes a lot of issues. For one, alcohol has a lot of calories. So if you drink a lot of alcohol after your surgery, you're likely not to lose the weight that you want. The other thing is the alcohol is absorbed quicker, and because you weigh less, you need less alcohol to take effect. So you need to really watch alcohol after surgery and make sure that you're taking care of yourself. We also get a lot of questions about plastic surgery and what do I do with all the extra skin after surgery. Well, we do offer plastic surgery after weight loss at the University of Washington Medical Center, and our plastic surgeons are very experienced in this issue. But we do want to make sure that we wait till the weight loss is finished. It doesn't make sense to have plastic surgery and then lose another 100 pounds and then have to have another operation. The important thing to know there, most insurance doesn't cover plastic surgery after weight loss unless you have documented skin care issues. So if you do have those issues, rashes, skin fold problems, make sure that your primary care doctor documents those things, and that helps when it comes time to ask insurance for coverage. We do a lot of research at the University of Washington Medical Center. It is important to know that if we ask you to participate in research, that research is voluntary. In other words, if you decide not to participate, it doesn't affect your care in the slightest. We do the same as physicians and nurses, regardless of whether you're involved in a research study or not. It doesn't change your operation, doesn't change your care. It's also important to know that if you do participate in research, that's kept confidential, and we don't release your information, your personal information, to anyone. We have our own website with a lot of good information on it, so feel free to go to our website at uwmedicine.org/bariatric for more information. Thank you for joining us today for our discussion on weight loss surgery at the University of Washington Medical Center.